1 in 3 adults alive right now has a liver condition serious enough to require a medical diagnosis, and almost none of them know it. There are no symptoms and no warning signs. It just quietly shows up one day as a slightly odd number on a routine blood test. It's called fatty liver disease. In this video, I am going to walk you through what it actually is, why the medical community formally renamed it in 2023, how it hides in your routine blood work, and most importantly, why it's one of the most reversible liver conditions out there if caught early. Let's get into it. So first, the name. If you've heard of this condition before, you probably know it as NAFLD, non-alcoholic fatty liver disease. However, in 2023, a large international group of liver specialist societies got together and formally renamed it. It's now called MASLD, metabolic dysfunction associated steatotic liver disease. The reasoning behind the change is really sensible. The old name defined the condition by what it was not, non-alcoholic, rather than what it actually is. And non-alcoholic fatty liver as a label was also considered stigmatizing for a lot of patients. The new name focuses on the real driver, metabolic dysfunction. Fat builds up inside liver cells, a process called steatosis, and it happens because of underlying metabolic issues such as insulin resistance, excess weight, high blood sugar, and high triglycerides, but not because of alcohol. Just a quick side note, there is also a new related category called MASLD, metabolic and alcohol-associated liver disease, for people who have this metabolic pattern and also drink alcohol at levels that add extra risk. So it's not always a strict either or between metabolic and alcohol. For a good chunk of people, it's both contributing at once. Now here is the number that should surprise you. A peer-reviewed meta-analysis published in 2024, pooling data from 78 million people across 38 countries, found the global prevalence sits at just over 30%, 30.2% to be precise, of the adult population. That's roughly 1 in 3 adults worldwide. And it's not staying still. According to a systematic analysis, the number of people living with this condition rose from around 500 million in the 1990s to about 1.3 billion in 2023, and is projected to climb to 1.8 billion by 2050. That's an enormous, quietly growing global health story, and most people affected by it don't even know it. So how does fat actually end up accumulating inside liver cells in the first place? Well, it comes down largely to insulin resistance. When your body cells stop responding normally to insulin, the liver ends up receiving an oversupply of free fatty acids. This happens for two reasons. Fat tissue elsewhere in the body breaks down more aggressively than it should, and the liver itself ramps up a process called de novo lipogenesis, literally new fat creation, converting excess dietary carbohydrates directly into fat. Normally, your liver packages this fat into VLDL, very low density lipoproteins, which is a type of cholesterol, to safely ship it out to the rest of the body. But when the liver is flooded with free fatty acids, the VLDL export system gets completely overwhelmed and maxed out. Once fat starts accumulating faster than the liver can export or burn it off, it builds up inside liver cells as small droplets. That's simple steatosis. But here is where things can turn dangerous. It's not just that these fat droplets are taking up physical space. The excess fat breaks down into toxic byproducts like ceramides, which essentially poison the liver cells from the inside. This is called lipotoxicity, and it causes the liver cells to swell up and die, a hallmark of MASH, known clinically as hepatocellular ballooning. When these liver cells get damaged and die, they sound an inflammatory alarm. The liver has its own built-in immune sentinels called Kupffer cells. They pick up on this cell death and start pumping out inflammatory signals. Those signals then activate a totally different group of cells called hepatic stellate cells. Normally, stellate cells just quietly store vitamin A, but once activated by this inflammation, they transform. They become scar tissue factories, laying down the rigid collagen that eventually causes liver fibrosis and cirrhosis. Researchers describe this entire cascade as a multi-hit process. It's insulin resistance, lipotoxicity, gut microbiome changes, and these cellular alarms all interacting together, which is exactly why the disease course varies so much between individuals with seemingly similar risk factors. So how does something this common stay so quiet? Because in the vast majority of cases, it causes no symptoms at all, at least not early on. The most common way people find out is completely by accident through a routine blood test. If you watched my video on liver function tests, you will remember that fatty liver disease is actually the single most common cause of a mildly elevated ALT today. Typically, what you will see is a mild elevation, maybe 1.5 to 2 times the upper limit of normal, sometimes with GGT mildly up to. Nothing dramatic, which is exactly the problem. It's easy to see a mildly abnormal number, shrug and move on, when actually it's worth a second look. So who is at risk? This tracks closely with metabolic health in general. The biggest risk factors are being overweight or living with obesity, having type 2 diabetes or prediabetes, high blood pressure, high triglyceride, and low HDL cholesterol. Basically, the same cluster of factors that make up metabolic syndrome, which I will cover in a separate video. The more of these you have stacking up, the higher the likelihood. But it's worth saying clearly, this is not a condition that only affects people who are visibly overweight. A meaningful number of people with completely normal body weight still develop it, usually because of how and where their body stores fat internally, even when it doesn't show much on the outside, sometimes referred to informally as lean MASLD. It's also increasingly recognized in children and adolescents, tracking closely alongside rising rates of childhood obesity, which is why current pediatric guidance now recommends considering screening in children with obesity and additional risk factors, a significant shift from a generation ago when this was thought of purely as an adult middle-age condition. Now, here is the part that actually matters most. Fatty liver disease exists on a spectrum, and where you sit on that spectrum changes everything. At the mild end, you've got simple steatosis, just fat accumulating in the liver cells, largely reversible and usually not causing much harm on its own. For a minority of people, it progresses to a more active inflamed stage called MASH, metabolic dysfunction associated steatohepatitis, where the liver isn't just storing fat, it's actively inflamed and being damaged. Left unchecked over years, that inflammation can lead to fibrosis, scarring, and in the more advanced cases, and a smaller subset of those with cirrhosis go on to develop liver cancer or liver failure requiring transplant. MASLD-related cirrhosis is now one of the fastest growing reasons for liver transplantation in several Western countries. The critical thing to understand is that most people with fatty liver disease never progress past that first mildest stage. But because it's so common, even a small percentage progressing to serious disease adds up to a lot of people, which is exactly why catching it early and monitoring it matters. Given how common this is, who should actually be getting checked for it proactively rather than stumbling onto it by accident? Current Liver Society guidance recommends targeted case finding rather than screening the entire population, meaning testing is focused on higher risk groups rather than everyone. That specifically means people with type 2 diabetes, people with obesity plus another metabolic risk factor, and people with a persistently abnormal liver panel and no other obvious explanation. For these groups, it's increasingly recommended to calculate a fibrosis risk score like the FIB-4 we will cover shortly as a first-line step rather than waiting for symptoms that, as we've covered, usually don't show up until fairly late. Now for the encouraging part. Unlike a lot of chronic liver conditions, this one responds remarkably well to lifestyle changes, and we have real data on exactly how well. Studies show that people who lost at least 5% of their body weight saw the disease resolve completely in 58% of cases, and people who lost 10% or more, 90% saw their liver inflammation resolve, and 45% actually saw measurable regression of existing fibrosis, actually scarring, reversing. That's a genuinely rare thing in medicine. A serious organ disease that can meaningfully reverse itself with sustained lifestyle change alone, no medication required for milder stages. For more advanced cases, there is also a significant recent development worth knowing about. For decades, there was no medication specifically approved to treat MASH itself. Lifestyle change was the only tool. That changed in 2024 when resmetirom became the first medication approved by the US FDA specifically for adults with MASH and moderate to advanced liver fibrosis, used alongside diet and exercise, not instead of them. It works by selectively activating a thyroid hormone receptor in the liver, which helps reduce liver fat and, in trial data, improved fibrosis in a meaningful proportion of patients without worsening the disease. It's not for everyone. It's specifically indicated for people with confirmed, more advanced fibrosis, not simple steatosis, but it represents the opening of a new treatment era for a condition that until very recently had no dedicated pharmacological option at all. So if a blood test flags this, what actually happens next? Usually, the next step is a simple calculation your doctor or the lab can run using numbers you already have, called the FIB-4 score. It combines your age, your AST, your ALT, and your platelet count into one number that estimates your risk of significant liver scarring, no extra blood draw required. A low score, under about 1.45, is genuinely reassuring. In validation studies, it correctly ruled out advanced fibrosis about 90% of the time. A high score, above about 3.25, means it's time for more specific testing. FIB-4 is not the only calculator in use. The NAFLD fibrosis score works on a similar principle, combining age, BMI, blood sugar status, platelet count, albumin, and the AST to ALT ratio into a single risk estimate, and the APRI score offers an even simpler alternative. They are all indirect calculators. They use routine metabolic and liver numbers to estimate risk without an invasive procedure. But what if those indirect calculators give a borderline or unclear result? That's where a more specialized test called the ELF score comes in. ELF stands for Enhanced Liver Fibrosis. Unlike FIB-4, which reuses routine numbers, the ELF score or the ELF test is a dedicated blood draw that measures 3 direct markers of liver scarring. It measures the actual protein and structural components your liver releases when it is actively building and breaking down scar tissue. The lab combines these 3 markers into a single score. A lower score, typically under 9.8, usually indicates a low risk of severe scarring, while a higher score acts as a strong red flag that more advanced fibrosis is likely present. This helps doctors decide who really needs a specialist referral and who can safely continue managing their condition in primary care. If scores like FIB-4 or ELF come back high, The next step is usually an ultrasound or a specialized scan called elastography, sometimes known by the brand name FibroScan, which measures liver stiffness directly and non-invasively. Biopsy, actually taking a tissue sample, is now reserved mostly for unclear or higher risk cases. It's far less routine than it used to be, precisely because these blood-based tools and imaging scans have gotten good enough to avoid it in most people. So a quick recap. Fatty liver disease, now called MASLD, affects 1 in 3 adults worldwide, develops through insulin resistance driving excess fat into liver cells, usually shows up first as a mild, easy to miss abnormality on a routine liver panel. While it can progress to serious disease in a minority of people, it's also one of the more reversible chronic liver conditions we know of, especially when it's caught early, now with a first dedicated medication option for more advanced cases too. If you haven't already, go watch my full breakdown of liver function tests, link in the description. It's the perfect companion to this one. And if this helped make sense of a health topic that affects a huge number of people quietly, hit subscribe and share the video. With that said, thanks for watching and I'll see you in the next one.